We are live.
Good evening. I welcome everyone to today's iFocus online lecture number 489. Today we have Dr. Gaganjeet Singh Gujral, sir, Senior Consultant at Center for Sight Eye Hospital, New Delhi, to teach us about retinal detachment repair after laser vision correction surgery. Welcome, sir. We have Dr. Pooja Bansal ma'am to moderate today's session. After finishing her MBBS from Government Medical College, Chandigarh, she finished her MS from PGI Chandigarh, followed by DNB and FICO in UBA. She finished her senior residency in Vitreoretina and UVA from PGI Chandigarh, senior research associate in PGI MER and Dr. RP Center, AIMS, Delhi. She was an ex-faculty with GNEC, Maulana Azad Medical College, Delhi. She has a keen interest in academics and research. She has trained several postgraduates and fellows. Currently, ma'am is a senior consultant, Vitreoretina and UVA at Center for Sight Eye Institute, Dwarka. She has won several awards for best paper presentations and national and international conferences and has several indexed publications in national and international journals along with book chapters. Welcome, ma'am, and over to you for the introduction of our chairperson, respected Dr. Avnindra Gupta, sir, and our speaker, Dr. Gaganjeet Gujral, sir.
Thank you, Dr. Krutika, for a kind introduction. It's my pleasure to introduce Dr. Avninder Gupta, sir, a very dear senior of ours, an excellent vitreoretinal surgeon and a clinician par excellence. Sir actually needs no introduction. Just to brief, sir is a graduate and postgraduate from BHU Varanasi, and he did his fellowship in retina and vitreous from Aravind Madurai. Sir is currently heading Nayan Jyoti Eye and Laser Center, Faridabad, and Sir is also associated as a senior consultant with Center for Sight, New Delhi. Sir also headed the Department of Retina and Vitreous at Aravind Eye Hospital, Tirunelveli. Sir has multiple publications in national and international journals and also presentations. He has trained several ophthalmologists, delivered many lectures in national and state level conferences. And Sir, the Best Surgical Video Award, that is the Mystery Unfolds at URETNA Congress, which is a great honor as this was the second time this award had been bestowed to an Indian ophthalmologist. It's a pleasure to have you, sir. Thank you for taking out time to be a part of this session. Now, Dr. Gaganjeet, the speaker of today's session, is a young dynamic ophthalmologist, again a meticulous surgeon and an excellent clinician. He did his MS from Institute of Ophthalmology, Aligarh Muslim University, and then pursued his vitreoretinal fellowship from Shroff Charity Eye Hospital, and also did his fellowship in cataract microsurgery from SN Chennai. Currently, he's working as a consultant and vitreoretinal surgeon at CFS Dwarka. He has many publications in national and international journals. He has many awards to his name. The latest one is Dr. Arjun Narang Trophy in annual DOS 24, and Dr. V.N. Raiza the gold medal. And he off and on keeps on winning some or the other prize in DOS conferences. He's very good in retinal imaging, retinochoroidal imaging, and he also won the first prize in image and video competition held by VRSI. And Gagan will be talking on a very important topic, the detachment surgery, retinal detachment surgery in patients post-LASIK. These patients usually are high myopic. They are very anxious because of their myopia. And also when they are planning for the LASIK surgery, they have a long list of questions to the LASIK surgeon. And on the top, if the patient has been detected with some lesions in the retina, some weak lesions which need some treatment, then to the retina surgeon. The questions are regarding why these lesions are there, why this weakness is there, how to treat them, how to follow them, what is the prognosis. So Dr. Gagan will be addressing all these questions today. Over to you, Dr. Gagan.
Thank you, Dr. Pooja, ma'am. Is my screen visible?
Yes,
Yes, sir.
Dr. Gagan, it's visible.
So today, good evening, one and all. Today, I'm going to speak about retinal detachment repair after laser vision correction. Refractive errors. So uncorrective refractive errors are the most common cause of moderate to severe impairment in young adults. Refractive errors which are seen in day-to-day practice include myopia, hypermetropia, astigmatism, and presbyopia, of which myopia is the most common. There is either a steep cornea or a longer axial length or a combination of both in myopia. There have been very great advancements in refractive procedures to treat these refractive errors. For myopia, the latest one being the smile and silk procedures, and LASIK being there for a long time. There are some older procedures like RK which are not done, but we still get follow-up patients and to get to see complications which have happened in these patients. So peripheral retinal degenerations. Degenerations involving the peripheral retina are common in myopes, and studies have shown a higher prevalence with increasing grade of myopia. These include lattice degeneration, slant tract degeneration, retinal tears, holes, degenerative retinoschisis, tufts, and rarely zonular traction tufts can result in rhematogenous RDs and its associated morbidities. A PVD also occurs much earlier in a myopic patient. So there was a study in a IGO by Ramesh et al., where the expert panel identified the following peripheral retinal degenerations which can predispose to RDs. These include lattice degeneration, snail tag degeneration, degenerative retinoschisis, cystic and zonular tractional retinal tuft, retinal tear, and retinal hole. The following lesions have been identified by that expert panel for treatment with laser therapy in order to prevent a possible RD. Lesions which predispose to RD in a patient with recent onset flashes or floaters, lattice degeneration with a hole, retinoschisis with RD, presence of a HST or a horseshoe tear or retinal dialysis, presence of retinal hole with a cuff of surrounding SRF, traumatic retinal breaks, lesions predisposing to RD in patients undergoing refractive surgery, cataract surgery, laser capsulotomy, or intravitreal injections, lesions which predispose to RD in the fellow eye of an RD patient or a patient with single light status. And some syndromic patients like Marfan's or Sticklers may need a prophylactic laser treatment. Therefore, all patients who are scheduled for refractive surgery should undergo a dilated retinal examination, followed by examination by either a specialist. If he or she is unavailable, you can do a ultra wide field imaging. Then, if a peripheral retinal lesion is noted, treat that lesion, barrage it with laser, and wait for at least 2 weeks, following which do another evaluation. Once you feel that all the lesions are well lasered, you may plan the refractive surgery. If on examination no treatable lesion is noted, you may proceed with the refractive surgery. But keep in mind that even after a refractive surgery, the patient should undergo a regular follow-up. And if he has any symptoms like flashes or floaters, an urgent review should be done by the patient, and these things should be made aware to the patient. The LASIK, which is done in most of our patients, certain changes occur in the ocular parameters. There is an increase in IOP during the application of microkeratome suction ring. An acoustic shock wave is occurring during the laser ablation, and a rapid lowering of intraocular pressure when the suction ring is decompressed. All these have potential to cause changes in the vitreous retina as well as in the central portion, the macula. Retinal tears and detachments are the most important types of posterior segment complications. However, the cause and effect relationship remains controversial. So one could argue that this is prudent in myopes whether or not they undergo LASIK, given the potential of the procedure to exacerbate this pre-existing pathology. It might be wise to treat such lesions more aggressively. Retinal detachment is one of the most dreaded complications, luckily in spite of its low occurrence. In general, the risk of developing RD in myopic patients have been considered to be 3 to 5 times higher for low to moderate, which increases to as high as 15 times. The risk appears to increase almost 10 times higher when accompanied by a lattice degeneration. And in high myopes with lattice degeneration, the risk is nearly 200 times higher. Regarding etiology, the risk of retinal detachment in myopes is attributed to the anatomical and physiological changes that occur. These changes are the greater axial length, thin and fragile sclera, choroidal hemodynamic changes, early and a strong liquefaction of the vitreous, followed by an earlier PVD and complex vitreous retinal interface, pathological vitreoretinal attachments with higher peripheral retinal break occurrence, irregularity of the posterior border, posterior staphyloma, posterior degenerations, and a weak retinal adhesion. However, over a long time, it appears to be a part of natural history of myopic eyes with vitreous modifications over time. In the study by Srinivasan, the median time of development of RD after LASIK was 12 months, which makes it unlikely to be a direct cause of the rise in intraoperative pressure of IOP. Had it been the case, we would have cases of RD developing very early after the refractive surgeries. LASIK is again a bilateral procedure, but in this study, only 2 patients were found to be with bilateral RDs. And other studies have also shown low numbers of bilateral involvement. That means that this is a part of the natural course of myopic eyes that leads to RDs and not due to LASIK or the refractive procedure per se. In the series by Fagany, they found that there was increase of odds of RD in older age group with increased severity of myopia as compared to males who were reported to have a higher risk. There was no significant association found with the age at which the LASIK was done, the gender, the laterality, or the preoperative spherical equivalent with the development of RD. However, at the time of development of RD, patients presented with lattice with holes. It may be due to acute PVD with the formation of breaks and holes, which can later cause RD occurring months after the LASIK surgery. However, the occurrence of PVD can theoretically induce retinal tears at the edge of critic area and still can produce RD. Therefore, this is a limitation of prophylactic treatment of lattice degeneration and not a complication. So even if you have prophylactically treated a lattice degeneration, a PVD can still induce RD at the edge of that area, lifting it up and leading to SRF going beneath the retina. Therefore, there is little data to determine if there is a positive relationship between LASIK and vitreoretinal disease. Myopics undergo LASIK in increasing numbers, and these patients are predisposed to RDs as well as other macular pathologies like macular hemorrhages, CNVM, which will occur otherwise also. So it is possible that these abnormalities or an exacerbation of these conditions are associated with the LASIK procedure itself. However, the pathologies may have occurred anyway without refractive surgery. Therefore, an ideal thing would have been to plan a controlled study. So for RD, once it has occurred, there are various options that are available. There is cryopexy or argon laser retinopexy along with pneumatic retinopexy, a vitrectomy 23 or a 25, even a 27 gauge vitrectomy without a scleral buckle. These procedures are more appropriate because these techniques do not change the shape and length of the eye. And after that, the refractive errors doesn't appear again. As opposed to scleral buckling, which involves placing a band or an implant outside the eye to push the sclera inward and help the retina reattach. This leads to post-surgical refractive changes, which would be a obstruction in the surgical benefit which the patient had earlier taken. So in this patient, I would just give an example. This is an RD post a patient who had undergone a SMILE procedure 1 year back. So you can see how liquefied and degenerated the vitreous is. First, we do the vitrectomy, and you can see there was a large tear superiorly, which was very close to the superior arcade. Therefore, to stabilize that tear from inferior portion, I used PFCL, as well as these myopic patients are more prone to bleeding, which might percolate and go under the macula. Therefore, better to put PFCL to stabilize the central portion and then proceed further with vitrectomy. So this is a large tear which has occurred in the superior quadrant, and if you can see, there is this lattice degeneration, and from the edge, this has lifted. We remove the vitreous from the surrounding area, then mark the tear. Here you have a pre-lasered lesion, and there is a limited RD beneath that limited lesion by laser. Then you have to mark the lesion with a dithermy and remove the overlying flap. Completion of vitrectomy followed by fluid air exchange. Removal of the PFCL bubble. Do a thorough 360-degree laser barrage. So we have created a broad band underneath the superior large break and even added more laser in the inferior portion where the pre-existing laser marks were there, followed by an endotamponade in the form of silicone oil. So this was a case generally we follow. We generally prefer vitrectomy in a case of RD following a refractive surgery with an endotamponade. Generally, we use silicone oil. And if you have a very clean case, you may plan an endotamponade in the form of a gas. There are surgical challenges in these patients. What are these challenges due to? Mainly due to the higher axial length, the presence of RK scars, as I had told earlier, because these patients now come up with RDs, they are generally pseudophakic. Patients who have phakic IOLs are difficult to operate. These myopic have degenerated multilayered vitreous. There is posterior staphyloma, thin and atrophic retina. Sclera is also thin, and you may have associated macular holes. Corneal issues. When treating post-LASIK eyes, vitreoretinal surgeons should avoid debridement of the corneal epithelium to avoid flap displacement. However, when necessary, corneal debridement should begin nasally and advance temporally, as most flaps hinges are nasal. A preventive measure to preserve the corneal epithelium is the use of good non-contact wide-angle lenses. Surgery in these eyes may be associated with intraoperative complications of rapid corneal haziness or a LASIK flap dehiscence. There have been reports of corneal flap dehiscence even 7 months after LASIK done. So these observations are in accordance with a study which showed absence of bridging collagen fibers and cells between the flap and the stromal bed, indicating lack of wound repair at the LASIK interface. Therefore, the need of proper visualization system is the need of the hour, and we are blessed to have such wonderful instruments. We generally use the Recite instrument. There obviously is the age-old binocular indirect ophthalmoscope microscope or the biome, and some surgeons prefer the IBOS. So these are three premium non-contact viewing systems which provide ease during the surgery and are particularly useful in these high myopic eyes with corneal changes to help us visualize the cornea and the retina. So this is a case where you can see that he had received RK, and you can see these RK scars. After the ports, we am doing the anterior vitrectomy and clearing the vitreous from underneath the lens. And this is the Recite viewing system that has been applied. Again, you can see how liquefied and degenerated the vitreous is. You can see there is a large tear in the superior portion. Then a vitrectomy is started. Here again, you can see that there is a tear adjoining which there is a pre-lasered scar and adjoining which a tear had occurred. So as discussed earlier, a PVD can still cause an RD in a patient who has already received laser. Therefore, a proper follow-up even after a refractive and a surgery like LASIK mandates that you have to have a proper retina follow-up. The higher axial length, the instrumentation reach is the major issue. What can we do to help that issue? You can increase the distance between sclerotomies, not necessarily make it at 3.5. You may proceed because the aura is slightly posterior in a myopic patient. You may go to up to 4 or 4.5, provided you have indented and seen that you are not going beyond the aura. If it is very difficult, you might prefer earlier instruments, a 23 gauge or a 20 gauge instrument. You may remove a trocar and go slightly more towards 3 and 9 o'clock so that you may proceed in and reach the depth of the eye. So this is a patient, a high myopic patient, where this is a case after a silicone oil removal. The retina is attached. You can see the old laser scars. Myopic maculopathy is there. So I'm started a fluid air exchange. I'm using a fluid. But there is still some amount of fluid left at the posterior pole. I could not reach with an instrument. I changed my instrument, which has a small sleeve, so that I could reach up to the disc. And remove the SRF. You could see these are my thumb or the fingerprints because I'm trying to hold the instrument more obliquely so that I can reach to the depth of the eye. These certain changes help us reach the posterior extent of the macula. The vitreous is also more degenerated and multi-layered in these myopic patients. To help us remove that, you have to use valve cannulas with low flow to minimize turbulence, and a proper staining with triamcinolone is a mandatory thing. You may stain again to see whether you have left any vitreous or any layer of vitreous is still stuck behind after completing vitrectomy. So this is a patient which had a temporal RD with involvement of the fovea. Do just a little bit of pore vitrectomy, clear a little bit of vitreous. You can see lattice degeneration in the superior portion, which is unlasered. So this might have been missed prior to the surgery, prior to the refractive surgery. And something like that might have led to a tear in the temporal half. This is triamcinolone being injected. Remove a slight bit of excess triamcinolone. Switch off the cutter. Slightly raise the vacuum. I have increased the speed, so this is not the natural surgical speed, but gently, with gentle movements, try to peel off the vitreous. These are generally young patients, so it is quite sticky and difficult. So this is the PVD, the V-ring. Now with it, lift it and complete the vitrectomy. There are cases of posterior staphyloma in these myopic eyes, which have decreased contrast. You have increased myopic chorioretinal degeneration and difficult to make out the tears and parts of the retina. You need a proper visualization system. You may use a PFCL to flatten the retina if the involvement is within the staphyloma. There may be multiple holes with posterior extension, large tears, a giant retinal tear, decreased contrast, and increased risk of iatrogenic tears also occurs in these post-refractive surgeries RDs. Therefore, marking the tear or hole with diathermy is a must. So earlier I had shown the left eye of the patient, the first video. This is the right of the same patient. You can see these RK scars. So the left eye was involved earlier, and 1 year later, the patient presented with retinal detachment and a vitreous hemorrhage in the right eye. So now we operated the right eye. So here you can see this is the vitreous hemorrhage. We clear the vitreous hemorrhage. You can see the old laser marks, and you can see a superior tear adjacent to the old laser marks, which we had done for this patient earlier. So this is clearing of the vitreous. This, you can see how from the edge the tear has lifted and the retinal detachment has occurred. You can see the laser CRA here, the retina has lifted. So you clear the vitreous over the tear as well. Mark the tear in order to cauterize any bleeders also. And once, because you'll have to shave off this tear, otherwise it will keep coming in your port and might lead to further extension of the RD. You can see how mobile the retina is and how thinned out. You have to be very careful in order to prevent any iatrogenic tears. You mark the huge tear that is there, the flap that is there. Remove it with the cutter. Remove the vitreous from near the ora. You could see how during fluid air exchange, the visualization was difficult. There is fogging, so you use a cotton wedge. You put visco behind the IOL, visco over the cornea. All these things help improve the visualization, which is generally hampered in such cases. Right, gentle massaging from the cotton bud, not very vigorous. Then a laser is completed. Both anterior and posteriorly, you surround it with laser, followed by a silicone oil tamponade. A thin sclera is a difficult thing when you are trying for a scleral buckle. We generally avoid doing it in post-refractive surgery cases. So, but if there is a need, you might proceed with it, but you have to be careful. Avoid the thin areas which may appear as bluish black areas and try to have a shallow buckle. Then an associated macular hole is also an important complication that may occur in a myopic patient. A proper staining is very important, and a judicial use of PFCL can also be done in cases of macular hole. So this is when I had not shown, I had stained twice. The first stain didn't come, so I had stained again second time so that you could see how diffusely the chorioretinal degeneration is there. It doesn't take up the proper stain. This is the macular hole, and you will see how difficult the visualization is because it is a very long eye and it becomes hazy. First, you judge whether the instrument is reaching up to the macula. I generally prefer the pinch and peel technique. These are all fast forwarded videos, at least 2x or 4x. All these maneuvers are done gently. I'm trying to create a flap and place it over the macular hole. This flap was then placed and a fluid air exchange done with a soft tip cannula. Luckily, this patient did well, recovered a visual acuity of 612 with a macular hole closure, despite having a advanced myopic chorioretinal degeneration. But many of these patients have poor visual outcomes, which may be attributed to a long interval between the onset of symptoms, including the PAVR that contributes to the poor final visual acuity. In some cases, there is a delay in the patient's referral to the vitreoretinal specialist because it is thought that the symptoms are due to refractive or corneal problems rather than a retinal problem. Despite high anatomical success, reasons for poor visual acuity include the development of ERMs, epiretinal membranes, advanced PVR cases, myopic maculopathies, or optic atrophies, because the optic nerves are also thin and any changes during the surgery, the pressure changes, can impact the vascular supply of the nerve itself. Final visual acuity may be limited by myopic degeneration, amblyopia, or a delayed referral to a vitreoretinal specialist. TRTs also occur most frequently in association with myopia, and when these both factors coexist, the risk of DRT is further increased in a case of trauma. Farah and co-authors reported 2 cases of GRTs following LASIK for high myopia. The retinal detachment developed less than 3 months after surgery, and the final visual acuity was very poor, 20 by 400 and LP. Osdamer et al. Reported a case of simultaneous bilateral retinal detachment associated with GRTs after LASIK in a high myopic patient. Overall, PVR grade C was present in almost 17% eyes in this study by Narcis et al., where the surgical outcomes were assessed. Of these, only one eye with PVR grade CP1 underwent scleral buckling, while others went a pars plana vitrectomy. So several forms of retinal detachment have been considered as complex. Most of these cases, unfortunately, are complex with multiple tears due to GRTs and those with PVR in the RTs following refractive surgeries. So these observations show that the functional result may not be as satisfactory as the anatomical results in the eyes with post-LASIK RRT. At times, you may have to be very aggressive and even remove the ICL so that you can give or save the retina and the eye. So this is a case which was referred from a peripheral center where an ICL removal is being done. The patient had an RT operated, but he had a recurrence. In fact, she had a recurrence with advanced PVR. So first we removed the ICL, did the cataract surgery or did the lens aspiration, followed by the IOL implantation, followed by the retina surgery, which I'll show after this video. So you try to maneuver the ICL into the AC. With judicial and copious use of visco and viscoat as well, coat the underneath of the cornea. Try to engage the holes and lift it. Here comes the ICL, followed by the cataract surgery and placement of the lens, followed by the suture, and then we proceed with the retina surgery. So here you had a recurrence of RD with an advanced PVR. Very important to remove the membranes, the PVR. Here you can see the lifted up retina in the periphery, and that was all 360-degree, including the areas which were lasered. Difficult in visualization. You try to remove all the adherent membranes, peel them with gentle scraping and using of the suction. And the uses of forceps remove all these membranes and make the retina more malleable to settle it. Use the PFCL. Advanced PVR, we have to do RR or relaxing retinotomies. In this case, almost a 300-degree RR was done. Increase the PFCL up to the edge of the lesion. Complete your laser. Do also the laser around the areas which were earlier lasered. Do complete 360-degree laser with a broad band. I generally prefer a direct PFCL silicone oil exchange. You're injecting oil and removing the PFCL at the same time. This is one patient with had a good anatomical outcome, but the visual recovery wasn't good. And she achieved a vision acuity of 6/60 on. So post RD repair, refractive errors can still occur. Wait for some time for possible spontaneous involution. In the meantime, correct refractive defects with glasses or contact lenses because these patients need a proper visual recovery. If you have used a buckle, you may remove the bucklings early after being sure that all the breaks have sealed. And the consideration of an additional refractive procedure in a patient is difficult to accept by the patient itself. To conclude, post-LASIK RDs usually occur in eyes with moderate to high myopia and may have a complex nature in terms of size, number, location, and types of retinal breaks, as well as high rate of PVR. Surgeons may face corneal flap complications in these eyes. Multiple procedures may be needed, and final visual results are usually not favorable. It is difficult to determine a cause and effect relationship between LASIK and RD. Findings suggest that every LASIK candidate should undergo a meticulous vitreoretinal examination. High myopia or a presence of extensive circumferential lattice degeneration may be a warning sign. The patient should be informed that the prophylactic treatment of peripheral degenerations does not have a proven efficacy in preventing RD following LASIK. Very important. It is important to inform patients that refractive surgery corrects only the refractive aspects of myopia, and the myopic eyes have the potential for serial complications even after undergoing a refractive surgery. A dilated fundus examination hence becomes even more important in post-LASIK patients whose visual acuity is not as good as expected to avoid delay and in referral to the vitreoretinal specialist. Thank you.
Thank you, Dr. Gagan. It was a very elaborative discussion on this such a complicated topic. So Dr. Gagan has beautifully summarized what all predisposing conditions need to be seen, evaluated, and treated in a patient who's coming for a retina workup screening prior to LASIK. Then,
Can you unshare your screen?
so as he said that we cannot establish a direct causal relationship whether these post-LASIK RDs are related to the LASIK procedure itself or because of the natural course of the disease, because of the vitreous liquefaction with time, and as such, their high myopia and retina, weak peripheral retina is one of the causative factor. And he is very nicely shown in the videos and otherwise in the slides also what all challenges we retina surgeons face while operating these high myopic patients. And he has also suggested various technical modifications, to neutralize these challenges. So I will be requesting Dr. Avninder sir to give some of his pearls and his opinion how he follows and treats such patients.
Thank you, Pooja. First thing is ki Gagan showed a lot of patients where laser barrage has been done, and then these patients ended up with retinal detachment. So one thing of advice is ki if you laser these lattices, go half disc diameter posterior to the lattice. You don't do laser just adjoining to the lattices. You go half disc diameter posterior to the lattices. So even if a acute PVD occurs and a tear occurs, which we know occurs at the posterior edge of the lattice, so that will be taken care by the laser. So you won't land up in with retinal detachment. So we should take precaution to go half disc diameter beyond the lattices. Very important thing what Gagan highlighted is you should know the patient has undergone refractive surgery and you should avoid scraping because if you land up with corneal edema and if you scrape the patient of LASIK, many times you can lose the flap. And nicely Gagan has enumerated how to proceed if you land up with one. And third thing regarding post-RK patient, you should be very careful that the pressure does not goes up very high. The pressure should be maintained, especially if pressure goes up once you do inject a silicone oil. Then you don't know how fast the pressure goes up. And many times if uh, the pressure goes up above 50 to 60 millimeters of mercury, these RK scars can give up.
Open up.
So, yeah. So you have to be very cautious in these kind of patients. Nice videos, Gagan, you have shown. Uh, if I feel ki the patient is very high myopic, the axial length is somewhere around 28, I prefer to put a band buckle in these kind of. My reasoning behind it is that the vitreous is very sticky And if you look at the vitreous base, it's very broad vitreous base. And you will not be able to do a good
Remove all.
base dissection in all these kind of patients. And with experience, you will also learn that uh, because of this broad vitreous base, many a times you land up with an peripheral detachment. So my preference is ki if the eye is very high, I'll prefer to put in band buckle to support the vitreous base slightly posterior. Uh, Fourth thing is that ki if you have an posterior staphyloма like what you showed, and the vitreous is ketic. So many a times you have a feeling ki you have removed all the vitreous, but once you put tricot or trimeslone, then this trimeslone sticks, and then you will realize ki it's the posterior sciatic vitreous which is still left. And if you leave this sciatic vitreous, you will land up with a redetachment. And that's what happened in your last case. The last case, what you remove was not membranes, it was a sciatic. So that important thing, that message should be very clear. If you are dealing with a very high myopic eye, then you will land up with an scatic vitreous. And if you remove many times what you see even with silicone oil, only the posterior staphylomas area gets detached. And this is usually because of the sciatic vitreous. You don't remove the sciatic. I'm emphasizing again and again because uh, as a retina surgeon, many of us don't remove this sciatic vitreous and land up with redetachment. I've learned a hard way around. Uh, and once I have started removing this sciatic vitreous in cases of posterior staphylomas, my redetachment rates have gone down. Uh, Fifth thing, what you showed nicely was in an atrophic retina, peeling an ILM. And these ILMs, if you don't stain, like you told, ki I was not able to get a good stain.
I did it
Many
twice.
times, huh?
I did it
Many
twice in
times,
that case.
yeah, many a times what happens is there is a sciatic vitreous, one thing. That is one reason why it's not staining. Second thing, you have an epiretinal membrane. Uh, in these situations, if you don't get a good stain with BBG at first go, stain with an reti blue and you will identify an epiretinal membrane, which is very difficult once you have an atrophic macula. Remove the epiretinal membrane and then stain with BBG, you will be able to peel this hilum. Uh, Otherwise, about relaxing retinotomies and 360-degree RRs, I'm not very enthusiastic about it because if you do all this RRs and it looks good on table, but post-operatively these patients don't do. So if I can remove the membrane, if I can support with peripheral buccal, if you have this kind of thing, it's better that you support it with a broad buccal in the periphery. Avoid doing retinectomies. Then these patients do good. Because if you do a good 360-degree retinectomy, many times, most of the patients, you are not able to remove the oil. There is an hypotony. 4 months, 6 months down the line, vision does not improve. So avoid doing this. Put a broad buccal to support the periphery to take care of your anterior PVR. I think most of your cases. Uh, Fifth thing, another point is once you have an multifocal lenses, uh, then there is very disturbing glare if you do an ILM peel or a membrane peel. So one thing what you can do, you can put visco that takes care of slight distortions. But uh, if you have an multifocal IOL or an ICL also, then there are disturbing glares which affects your surgical. I think otherwise it was a wonderful presentation. Anything else, Pooja, you?
Yes, sir. I had just one or two questions. One thing is, About the laser of the predisposing these conditions, many patients they already come with a lot of Google search and everything. So as of now, what we do is we even laser the pigmented lattices or lattices which have no holes. So that's what should be followed. That if even if there are no holes, but the patient is going to get a refractive surgery, we have to prophylactically barrage these lattices. If they are extensive, I say yes. But if they are just one or two, still they should be lasered, because I have seen some patients that who have undergone referred from outside just for a second opinion follow up, that there were some lattices but not lasered. So just
It's not mandatory to
my
laser all these lattices. You can leave this explaining, provided you explain the patient that follow-up is mandatory.
important. Second thing is, sir, uh, what just one or two, like the cornea surgeons have just discussed with, like sometimes if the patient has gone extensive retinal barrage laser or multiple settings, have you seen or have you have any experience or any discussion that they have some degree of persistent pupillary dilatation post laser, and which may cause trouble in centration while doing LASIK surgery?
Yeah,
Any sort
what happens if you do an extensive laser, you damage the ciliary nerves,
hmm,
and that leads to an accommodation loss. So if you do a very extensive barrage laser, patient will come up with complaints कि पास में देखने की दिक्कत हो रही है, and this usually resolves by somewhere around 3 to 4 weeks. So
okay.
you have to counsel the patients, yes. And this is other thing is कि whenever you are doing barrage laser in lateral meridian, you will see long ciliary nerves. So I tend to skip. I put a gap between those two ciliary nerves, and I don't directly hit over these ciliary nerves, because if you hit over the ciliary nerves, there will be an accommodation. And this is a known fact. And this is what we call as an accommodation loss post barrage laser, and this recovers by 3 weeks after.
So do if we notice such thing in patients, some patients, do we need to advise them to wait for the refractive surgery or then go ahead, or it doesn't affect the
No, you
outcome
will because the pupil dia will alter the ablation profile.
profile?
So you have to tell your patients wait for at least three to
Wait for
four
it. Okay.
weeks for the pupil to come to a normal.
Yes, that's it.
Sir, I had a doubt, sir.
Yeah.
Sir, so in cases where barrage laser is done, should we, may it be whatever, lattice or hole, should we ask all the patients to wait for 3 to 4 weeks, ideally?
See, if you look the scarring in laser, the attachment comes immediately,
Okay,
and the
sir.
scarring starts by 2 weeks, and the scarring is complete by 3 weeks.
Okay, sir.
Ideally, it should be done after 2 weeks, what Gaganjeet highlighted. But since the attachment is at the very same sitting, if the patient is from outstation, can
Mm.
take up the patient after 2 days. But it should not be very extensive labor.
Okay, sir. So we should assess the pupillary reaction post barrage and ideally should be post for surgery,
Uh, uh,
especially in a
these
case where.
these things only occurs if you do a very extensive laser, and
Okay, sir.
you treat the lateral meridians. We generally don't have lattices in the lateral meridian. It's either superior or lower. And being a retina surgeon, most of the retina surgeon knows if you hit on the ciliary nerves, then there will be an accommodation fallacy. And
Yes, sir.
actually, uh, the moment you hit a ciliary nerve, the
The
patient
patient.
becomes very uncooperative,
Okay.
and then patient does not cooperate, and
Painful.
we
Hmm.
need to defer it. So, what's my preference is I prefer to do the lateral meridian the last, and I'll skip the long ciliary nerve to prevent accommodation paralysis. Plus, the pain and the fear of pain. Uh, that is one reason I do all my lateral meridians in the last. I leave it for the last.
Okay,
So
sir.
we have a question in the chat box by Dr. Yamini. In pre-LASIK retinal examination, can we decide which patients are at a high risk for retinal detachment and if there is any need to close follow-up post-LASIK surgery? I think Dr. Gagan has already explained in his slides that patients with high pathological myopia with extensive retinal peripheral degenerations, lattices with holes, extensive vitreous schisis, all these patients, they may have a higher risk for RD due to the natural course of the disease. And yes, all these patients, ideally, they need a regular follow-up post-LASIK surgery, SOS basis if any symptoms, as we discussed, or otherwise a regular follow-up. Anything to add, sir?
Then we'll add.
Gagan?
I think so, ma'am summarized it, sir. That's good. Sir, I had one question that do you use gas in such patients? I generally prefer silicone oil. मतलब any case where you prefer कि नहीं gas से काम चल जाएगा.
It all depends what is the kind of break and is the kind of vitreous-based dissection you are doing.
Right. But
Yes,
in your opinion,
our
does gas lead to more cataract or silicone oil? मतलब I felt gas.
gas is more cataractogenous and genetics
Yes.
rather than silicone oil.
Sir,
But
is there
silicone
some
oil, one thing is mandatory that your base dissection should be. You leave a lot of vitreous in the periphery and you put silicone oil, you will land up within periphery.
Sir, is there something that, especially in patients who have posterior staphyloma, obviously we have multiple breaks or we have posterior breaks, we have to put oil. But is there that gas gives sometimes with the patients of posterior staphyloma or even in myopic patients, as we've discussed, seen that a pocket of fluid may be left at the macula, the posterior pole, the most dependent position. And Gagan has described how to. One thing is, you have said that if you have some residual shitic vitreous, I think I have experienced that those pockets they don't go at the macula. We have to restain and take out the vitreous. Second thing is, he has described how to modify the instrumentation and drain the fluid. But is that something that if we put gas in such patients with a good vitreous-based dissection, they give a better tamponade than oil because of the more biomancy and
If you have a big staphyloma, gas is preferred. But you should make sure that you have removed the sciatic vitreous.
shitic vitreous.
Yeah. My preference in always these kind of cases is oil rather than gas.
Yes, yes. And sir, the last thing is if these patients they have a myopic RD along with the MAC hole, still we prefer oil after an ILM peeling or gas.
And there are two things. One is MAC hole causing an RD, and second thing is an RD with a MAC hole.
The MAC hole.
So again, oil gives more confidence.
Confidence, yes.
Yeah, more confidence in terms of the post-operative assessment. And if you want to treat this as some pocket of fluid, what you have stressed,
Yes.
you can laser this under oil, but under gas.
Yes.
So one last question. Like in RD with macular roll, just like the case I showed, I peeled it in after SOR rather than during the first. So what's your preference? मतलब in every, this was an RD, not a primary macular hole. So I peeled it in the second sitting because that time the first thing was it was identified during the surgery itself. So I settled the retina first and the second sitting I peeled it. What's your stay on that,
I
sir?
prefer at the time I peel this at the tip. I have an macular hole. I'll prefer peeling it at the time of the first surgery. But many a times these holes don't close, then secondary intervention are required. My preference is in the first surgery I
First
go
sitting, sir.
under PFCA.
Thank you.
So thank you, Dr. Gagan, for such a wonderful discussion. It was really an eye-opener for all the attendees and especially for myself also. Those little bit techniques and modifications and all, how to follow such patients and to have these pearls of wisdom. surgery and clinical, acumen from Dr. Vininder sir. It was always a pleasure. He's a great teacher. Thank you, sir, for taking out time for, on such
Always
an
a pleasure.
topic.
Always a pleasure.
Thank you so much, sir.
Thank you for the wonderful presentation, sir. Wonderful discussion indeed. Good night, sir.
Okay. Bye.
Thank you, sir. Good night. Thank you,
Good
ma'am.
night, ma'am.
Good night. Good night. Thank you.